The alternative known genetic pathway for this condition, of course, is in hereditary hemorrhagic telangiectasia, where you have an ALK1 abnormality which mediates through a similar pathway. It seems in the most recent data that the microRNA is particularly important in this mechanism, and specifically microRNA 21, the 21 referring to the number of amino acids in the derivative protein. What about pulmonary hypertension and its outlook? Really, the modern era, perhaps, this being a condition that was originally diagnosed back in 1891, and first series wasn't until 1950 here in the States. The modern era really starts with the NIH registry, which demonstrated markers of survival, some of which we use for lung transplantation. The particular variables which have determined survival have included functional class, the presence or absence of Raynaud's phenomenon, its presence increasing your risk of an adverse outcome, high rate atrial pressure increases your risk of adverse outcome, higher pulmonary artery pressure increases your risk of adverse outcome, though not to quite the same extent that the other variables do. And higher cardiac index, of course, reduces your risk. So lower cardiac index is the direction in which an adverse outcome might be expected. Really, the WHO classification, functional class, I only really put up just to mention that, of course, fatigue and chest pain and syncope, features of any obstructive cardiac lesion, features, for example, of aortic stenosis as well as of pulmonary hypertension, are incorporated essentially into the NIH, the New York, NYHA classification of dyspnea as part of the WHO functional class. Well, there are several mechanisms by which agents can act in this condition. Those include the prostacyclin pathway, the nitric oxide pathway, and of course the endothelin pathway, essentially antagonistic to the nitric oxide pathway. And medications have been developed to attack each of those mechanisms pertaining to the control of vascular smooth muscle. As you see here. Well, perhaps a case would serve to illustrate some additional points. This is a 34-year-old lady who presented following her delivery from her second pregnancy, and unfortunately, as is not uncommonly the case, a family history of the same disease, suggesting that she might well have an inherited disorder. Back in January of 2006, she was functional class 3, and at that time she had a catheter with moderate elevation of pulmonary artery pressures, normal wedge, of course, and really a very respectable cardiac index at 3.3 at that time. She was treated with IV Epoprostenol, which is, of course, an analog of prostacyclin, Epoprostenol, and really did quite well initially. Later, bosantan was added, and subsequently sildenafil, and the patient was listed back in 2006 for lung transplantation. At that time, she had a relatively respectable axis, and you can see her V1 at that time really was relatively unremarkable. Although of note, even at that time, she had mild sinus tachycardia, which is somewhat unusual for these patients. Typically, they will tend to rate control very, very tightly in the 80 to 90 heartbeat range for a variety of reasons. By 2008, she was made status 7, which is our method of, in lung transplantation of suggesting that she does not need a transplant at that time, that she's too stable. But fairly quickly after that, only 3 months later, she was made active again, and again was class 3 with very significant symptoms. 6-minute walk was stable, but our assessment of her right ventricle and right ventricular end diastolic volume in particular suggested an unfavorable trend, and that's typically done by a cardiac MRI technique, as that has tended to be a better method often of assessing the right ventricle. In September of 2009, you can see her pulmonary artery pressures had risen, and you'll recall her earlier cardiac index of 3.3 is now down to 2.1. And indices such as pro-BNP have also risen, and of course she has, as a result of that cardiac index and rising PA, a very high pulmonary vascular resistance. And now you can see the sorts of changes that you sadly can often see in these patients. You, first of all, will note the change in the axis, the change in V1, with now really very prominent R waves, and the overall strain pattern present on this electrocardiogram. See if I can get this to work. This is back in February 2010. And you've got both the long axis view as well as the two-chamber view. You're seeing some compression of the left ventricle here. The pattern on these ECG echoes, is going to be one of progressive compression by the right ventricle of the normal but compressed left ventricle. And this is again from the same time period, just showing the massive reflux through the tricuspid valve, and that of course is the M mode there. By May of 2010, the same patient had pre-syncopal symptoms, and her pro-BNP was little improved by all the efforts that were undertaken. With a cardiac index down to only 1.9, the patient underwent an atrial septostomy to offload the right ventricle, a trade-off in essence between oxygenation of blood and the pressures to which the right ventricle is being subjected under these circumstances. In November, it was felt necessary because of partial closure of the shunt between the atria to redo the septostomy. And we also obtained a waiver for her lung allocation score, which brought her up to the 90th percentile for lung allocation scores. One of the challenges of these patients is that they can be extremely sick, and yet under the allocation system, they don't get the weighting that they need when they deteriorate, and in particular when their right ventricle deteriorates, which tends to be the core of the problem. In December 2010, the patient had 2 dry runs for transplantation. And I think you can appreciate by now that really we're getting very little movement in the right ventricle, and we're really seeing a very compressed with the displacement D shape of the septum from the right ventricle into the left ventricle. And again, you might notice that really the pulmonary artery pressures really haven't changed very much from February 2010. And one of the difficulties, and we'll come back to this, is that pulmonary artery pressures, although they're very impressive, tend not to represent very well the severity of the disease, particularly in the later stages. So in February of 2011, this poor lady had a right ventricular ejection fraction, again on cardiac MR, of 25%. From 190, she'd gone up to 229 mLs on her right ventricular end diastolic volume, which was clearly deteriorating. In May, her 6-minute walk was getting worse, although her NT-proBNP was actually somewhat improved. Again, not the best indicator of deterioration, certainly. By July, she had severe hemoptysis, was auto-anticoagulated to a level of 4.1, developed ARDS, ECMO was initiated, and 7 days later it was withdrawn. And really a very sad end to a very wonderful lady, and just illustrating the difficulty in trying to manage what amounts to a failing right ventricle under these circumstances. This was her ECG, again just demonstrating increasing strain pattern moving into frank ischemia. And you can see what's left of her left ventricle under these circumstances. This is a 28-year-old woman, functional class between 2 and 3, some symptoms, who had a 6-minute walk of 300 meters, NT-proBNP of 400, severe right ventricular enlargement, dilated inferior vena cava, clearly showing a well-filled ventricle, and right ventricular longitudinal systolic strain of -12%. For those not familiar with that measurement, anything less than -25% is typically abnormal. And you can see some of her other indices. Question is, you've got this lady, she's functional class 2 to 3. What would you use as a treatment for her at this point? Would you choose an oral agent? Would you consider a calcium channel blocker? Would you consider intravenous Epoprostenol or Flolan? You know, some people have broken this down in a very simplistic way on the basis of the level of the pulmonary artery pressure. Broadly speaking, I think it's fair to say that from less symptomatic patients, class 1 to 2, here you basically move in a diagonal direction. The more severe, the greater the tendency to go at an early stage to the intravenous agents. But of course, remember with the Epoprostenol, you're going to put a central line in, they're going to be on a pump, and their way of life is certainly going to be dramatically changed as a result of that intervention. So it's certainly not a trivial intervention. As a result of a number of different meetings over the last 10, 15 years, the general classification of primary, secondary pulmonary hypertension has changed. We typically used to classify primary pulmonary hypertension as idiopathic, and all of the above would come under the category of secondary pulmonary hypertension. That's changed a little, and we now have many of these conditions being felt, as you can see, particularly the genetic and familial, to be much more in the category of the plexogenic primary pulmonary hypertension category. And instead, we have, and that's the reason, those are the reasons, the rationale of the various meetings about that. If you look at survival in pulmonary hypertension, it hasn't changed a great deal in the modern era, but we've become perhaps a little bit better at identifying those patients who are likely to do well or worse. Not surprisingly, patients with functional class 4 tend to do more poorly. The difficulty, again, is being reliable in our predictions, which, of course, is a challenge in this as in many other conditions. Again, all of these have been used to try to determine prognosis, but really functional class, clinical status, and echo data probably are the most reliable indicators of prediction of death in these patients. Of the clinical variables, the things that you need to keep in mind particularly are scleroderma or portal pulmonary hypertension tends to have generally a worse prognosis for a number of different reasons. Male sex, older age, perhaps not too surprising, and again, perhaps not too surprising, limited exercise capacity has a significant impact. And of the laboratory values, underperfused kidneys and overdistended hearts tend to indicate, again, a later stage of disease. As far as factors which are least likely to predict death in patients with pulmonary hypertension, which of the following? Right ventricular size, right ventricular function, pulmonary artery pressure, left ventricular size, or pericardial effusion. If we look at PA pressures and we break the groups into pre-symptomatic and compensated, the lower functional classes, symptomatic and decompensating, and declining and decompensating, if we look at PVR, it reflects those groups relatively well. If we look at pulmonary artery pressure, there's a little bit of a problem with the more severe instances. And if we look at cardiac output, not surprisingly, as the composite of the, as PVR being the composite of the other two, it follows to some extent the PAP. If you look at PAP then, it's quite clear that you can have the same value in both second and third categories. You can be symptomatic and decompensating, or you can actually be declining in the last stages of your natural history and still have the same pulmonary artery pressure. Of course, you're all familiar with the sort of changes that you're going to see on a biventricular view of the heart. Typically, this is the normal. And of course, with enlargement of the right ventricle, you get compression of the left ventricle. Question is, which of these measurements is best able to predict risk? And this is under conditions where, just an example of one patient, always with severe right ventricular enlargement throughout. That was the course of the right ventricular systolic pressure assessed by echo. This was the right ventricular ejection fraction assessed by CT and MRI. This is the right ventricular end diastolic volume assessed by CT and MRI, which we've tended to find much more helpful, not surprisingly, as you can see there, than right ventricular ejection fraction. And this is the right ventricular size assessed by echo, which is also, when available, very helpful. So in essence, patients don't die from high pulmonary artery pressures. they die from the inability of the right ventricle to compensate. That is essentially the problem in this condition. And so, to some extent, it's fair to say that the adaptation determines outcome. Now, you can measure right ventricular size relatively easily, as illustrated here. The advantages, of course, of echo are that it's easy to obtain, if nothing else. By comparison with cardiac MR, it's certainly arguably a little cheaper. But cardiac MR has typically been used for its more precise measurement of right ventricular volumes when it's available. But it's all about right ventricular function. Basically, patients die because their right ventricle fails, which can manifest itself as acute heart failure, or it can manifest itself, of course, as fatal arrhythmias in these patients. So another question. With respect to right ventricular function in pulmonary hypertension, which of the following statements is true? Is it radial right ventricular contractility that's important? Is it right ventricular ejection by cardiac MRI? That is the gold standard. Is it, which people have suggested, is it that echo measures the longitudinal right ventricular contraction, which predicts the risk for future episodes of right heart failure? Or is it that RIMP by echo accurately reflects right ventricular dysfunction in this setting? Which is the best measurement? I mean, is there a good measurement for right ventricular function under these circumstances? I think those are fairly self-evident statements. There is no gold standard. And certainly right ventricular ejection fraction, in our experience, has not been the most robust measurement for these patients. That must be me, sorry. So if we look at right ventricular function by echo, unlike the left ventricle, radial contraction, as mentioned, is modest. It's predominantly a longitudinal contracting chamber. So basically, if you're going to look at that, you're probably going to want to look at measurements of the longitudinal axis, which of course would include TAPS. The trouble is, of course, it's quite prone to error. You can look at RIMP, which is a global measurement of both systolic and diastolic function, intraventricular contraction time and intraventricular relaxation time over the total ejection time of the right ventricle. But of course, as with all composite variables, it's subject to significant error. And you can look at velocity, displacement. Strain is typically, of course, really looking at deformation, and the way we do that is by speckle tracking echo. You can also use MRI tagging, Doppler-based echo, and of course deformation. If you look at longitudinal peak systolic strain, it's relatively sensitive and it's quite prognostic in pulmonary hypertension. It predicts disease progression relatively well in both PH and in right heart failure, and it predicts survival. Right ventricular systolic train is reproducible, correlates with echo measurements of right ventricular dysfunction and markers of severe disease, and it correlates with pulmonary artery symptoms, as well as specifically right heart failure and all-cause mortality, excuse me. And it's above everything else is valued because it has the potential to be an independent variable amongst a clutter of interactive variables. If you look at right ventricular afterload, there's a number of ways in which you can try to measure this, but PV cap is probably as reasonable as any. The other part of that question that was asked before was what is the role of pericardial effusion in these patients? It tends to be a very bad prognostic sign, probably because it reflects high pulmonary venous pressure more than any other reason, and rather than a risk of tamponade, which really is most unusual in these patients. Echo and cardiac MR findings that are associated then with poor prognosis in these patients include dilation of both the right ventricle and right atrium and an eccentricity index, the measurements of right ventricular function that were mentioned, pericardial effusion, right atrial pressure, which of course came out even in the original NIH study, a delayed relaxation mitral inflow pattern, pulmonary artery capacitance we just talked about, and severe tricuspid valve regurgitation. But pulmonary artery pressures not really so helpful, even though they're often very impressive numbers. Right heart catheterization, you need it. The temptation may be to start a patient on bosantan or a calcium antagonist at an early stage, but really the indication for a calcium antagonist, for example, is in a patient who has a response to vasodilation at the time of right heart catheter with a 10% or greater reduction in pulmonary artery pressures and or the same reduction in pulmonary vascular resistance. So we've gone through a number of different drugs, the development thereof. Epoprostenol has only been available on this side of the Atlantic since 1995, though with perhaps a similar period of experience since its discovery by Vane and others at Wellcome back in the 70s on the other side of the Atlantic. So really a fairly large experience with that drug now. And of course it is an analog of a naturally occurring substance. Bosantan as an endothelial antagonist, treprostinil as an analog, a phosphodiesterase 5 inhibitor in the form of the well-known sildenafil, iloprost, which is again just another analog of epoprostenol, another endothelial antagonist, and another one. And then, of course, the notion of different routes by which you might administer these. Iloprost, for example, doesn't have to be inhaled. It can be given intravenously. All of these analogs of epoprostenol can be given intravenously, but they can also be given by a inhaled route. As far as survival goes then, this is where we were in 1981 to 85 prior to specific therapies here. This is after the introduction of epoprostenol, and this is after the introduction of approved oral therapies. As a result, you really are looking at a much better natural history than the 2.8 years median survival, that was so sadly described in the original NIH registry. You now have, I think, reasonable recommendations for patients who have acute vasoreactivity, as we mentioned in right heart catheterization, those patients would typically get oral calcium channel blockers, and following the Rich paper from the New England Journal, would typically get Coumadin as well, though the data for that is really perhaps a little bit more questionable. But typically will get anticoagulated as well for in situ thrombosis. For more advanced disease, one would expect them to get essentially some of the more potent endothelin inhibitor and arguably at this point intervene with either epoprostenol or an analog of epoprostenol. The inhaled iloprost and the inhaled has to be given 6 to 9 times a day. It's not an easy thing for a patient to tolerate, although some people really prefer that to having the intravenous indwelling line. And of course, for the more severe grades, it's pretty much an automatic commencement on an intravenous continuous agent, and then consider atrial septostomy and very much refer for transplantation. And I think actually, arguably, think certainly at this stage also about the possibility of transplantation. The NIH data is quite old. There is now a prospective study, REVEAL, which amongst many other objectives, Ray Benza has developed and published a year and a half ago now, this grading system, point-based system. We live in the era of point-based CHADs and CHAD2s, and so we have the same thing in pulmonary hypertension now, where we basically have a simple scoring system for to try and determine the severity of the disease. And actually, it's pretty reliable in terms of splitting up more severe classes of disease, and the higher scores have been demonstrated in prospective follow-up, admittedly only over a 12-month period so far, to be associated with a worse outcome. So that's functional class, which we talked about. This is functional class with REVEAL of greater than 8, and this does give us some hope that we will be able to better separate out the more severe patients. So functional class 4, 6-minute walks, we would suggest that this is really the group that you most definitely need to be considering fairly urgently for lung transplantation or heart-lung transplantation, depending on the indices. Again, as mentioned, parenteral therapy here, calcium channel blockers if positive vasodilator response, and of course oral agents for the more mild disease, and of course combination therapy to consider and as mentioned. So better to combine the markers as much as you can, identify the high risk as quickly and as efficiently as you can. You know, it's difficult to know whether temporal changes are important. This is one of the conclusions of the REVEAL, or one of the suggestions of the REVEAL group. But again, I think we just need a little bit more data on that. And unfortunately, it's true that although survival has been greatly improved by these agents, ultimately these patients are still going to need lung transplantation. It is true, however, that if you look at the survival, at the number of transplants that are done for pulmonary hypertension, it used to be, back in 1996, this is just the International Society for Heart and Lung Transplantation Registry, that a significant proportion, 30% of all heart lungs are now almost never done operation, 11% of double lungs, and 7.5% of all single lungs were primary pulmonary hypertension. Now, double lungs has halved, and single lungs almost never done at all. So there's been a reduction in the number of patients who come forward. That's partly because they don't get the severity scores. It's partly because, of course, the natural history has also been changed in this condition. Just a very brief word about thromboembolic disease. Here you see a typical example, a rather nice example of what's going on. You can see the complete occlusion of the pulmonary artery on the right side, and this almost spider web-like structure that is sadly typical of thromboembolic disease. What you're really trying to separate out are the patients who have more distal disease from the patients who have more proximal disease. Surgically, that would be described as the more proximal disease would be stages 1 to 3. Stage 4 is typically the really quite distal disease. This is an example of what happens when you've got distal disease and you occlude your wedge pressure. You get a very gradual correction by comparison with the occlusion pressure in someone with more proximal disease. But as you can probably surmise, it's not always possible to get a nice clean curve like that, and it's not always easy to make that separation. As far as transplantation goes, this is just our own little figures. You actually do quite well with primary pulmonary hypertension. This is heart-lung primary pulmonary hypertension. This is double-lung primary pulmonary hypertension. Unfortunately, our experience, as with many others, is if you're looking at secondary pulmonary hypertension, particularly from scleroderma, the survival is significantly less favorable than that. So just some summary thoughts. With new onset exertional dyspnea, if you excluded everything else, if you've done your asthma workup, if you have no other reason you have no other cause, particularly in a younger patient, but in patients really of any age, think pulmonary hypertension, screen by a transthoracic echo, make the definitive if that shows pulmonary hypertension, and again, you have no other reason for that which can be treated, please think about going fairly quickly to a right heart catheterization. And then, of course, initiation of treatment is also important, and we're just down the road, so don't forget about us either. And any questions?
I may have missed it, but the age at onset, the curve.
So the age of onset typically for primary pulmonary hypertension, typically the 2nd to 4th decades. For PPH, again, family history is quite important in that regard. It's not uncommon for a disease. It almost behaves like a triplet repeat, even though it's not known to be a triplet repeat disease. It almost always presents a little earlier in subsequent generations. That tends to be the pattern. PPH that isn't obviously familial would tend to present it at that time, and often around reproductive events, whether it's a pregnancy or not, and obviously overwhelmingly in women. For the broader disease, add at least a decade, and sometimes 2, again, depending on which connective tissue disease or other cause you're looking at. All clear.
Yeah.
Most welcome.